Immunosuppressed patients are susceptible to infections in the immunocompromised. Immunosuppressed patients are susceptible to the same organisms that infect immunocompetent patients. However, one must be aware of several additional opportunistic organisms that may present in the immunocompromised. An immunocompromised patient with a focal air space opacity is most likely to have a bacterial pneumonia, most commonly pneumococcus, but TB should also be considered if the CD4 count is low. In contrast, multifocal opacities have a wider differential diagnosis including Pneumocystis pneumonia and opportunistic fungal infections such as Cryptococcus or Aspergillus. Pneumocystis Giravecci pneumonia. Pneumocystis giravecci, previously called Pneumocystis carinii, is an opportunistic fungus that may cause pneumonia in individuals with CD4 counts less than 200 cells per cc or other T-cell deficiency, e.g., status post-bone marrow transplant or solid organ transplant. The incidence of Pneumocystis pneumonia is decreasing due to routine antibiotic prophylaxis. Pneumocystis pneumonia. Radiograph top left image shows multiple upper lobe predominant airspace opacities. CT top image shows crazy paving arrows with confluent ground glass attenuation in the upper lobes. Axial CT in a different patient with Pneumocystis pneumonia, bottom left image shows asymmetric ground glass opacification, with thin-walled cysts. Cases courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Chest radiograph findings can be normal, but a classic finding of Pneumocystis pneumonia is bilateral peri-Heiler, central airspace opacities with peripheral sparing. The classic CT appearance is ground glass opacification, sometimes with crazy paving, ground glass and thickening of the interlobular septa. A normal CT rules out Pneumocystis pneumonia, however, the disease can hide in a normal chest radiograph. Pneumocystis pneumonia has a propensity to cause upper lobe pneumatocells, particularly if untreated, which may predispose to pneumothorax or pneumomediastinum. Cryptococcus neoformans. Cryptococcus is an opportunistic organism and is the most common fungal infection in AIDS patients. Pulmonary infection usually coexists with cryptococcal meningitis. Typically CD4 count is less than 100 cells per cc in affected individuals. In the immunosuppressed, Cryptococcus can have a wide range of appearances ranging from ground glass attenuation to focal consolidation to cavitary nodules. Cryptococcus can also present as miliary disease, often associated with lymphadenopathy or effusions. Aspergillus. Overview of Aspergillus. Asthma or CF. Pre-existing cavity, e.g., sarcoid, TB. Chronic lung disease like emphysema. Neutropenic or immunocompromised. Number 1F GER in glove sign. Mucoid impaction of bronchiectasis. Mobile mycetoma monode sign. Air surrounding mycetoma. Chronic consolidation cavitation. Bronchopneumonia centrilobular nodules tree and bud nodules. Halo sign. Acute infection. Peripheral ground glass. Air crescent sign. Crescentic air in a cavity. Increased inappropriate immune response. Abnormal lungs or abnormal host. Invasive disease seen in the immunocompromised. Aspergillus is a ubiquitous soil fungus that manifests as 5 distinct categories of pulmonary disease. Aspergillus only affects those with abnormal immunity or pre-existing pulmonary disease. Depending on the manifestation, the predisposing abnormality may include asthma, immunocompromised state, prior infection, or structural congenital abnormality. Allergic bronchopulmonary aspergillosis, ABPA. Finger in glove sign of ABPA. Chest radiograph shows upper lobe predominant bronchiectasis with branching peri-Heiler opacities. CT shows dense bronchial mucoid impaction representing the finger in glove sign arrow. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Allergic bronchopulmonary aspergillosis, ABPA, is a hypersensitivity reaction to aspergillus seen most commonly in patients with long-standing asthma. ABPA is not an infection. Patients present clinically with recurrent wheezing, low-grade fever, cough, and sputum production containing fragments of Aspergillus hyphae. The diagnosis may be made using serum testing for Aspergillus IgG. The key finding on CT is central bronchiectasis and mucoid impaction, which can be high attenuation or even calcified. This combination of mucoid impaction within bronchiectatic airways represents the finger in glove sign. The finger in glove sign is not specific to ABPA, however high attenuation mucus is a specific finding. Saprophytic aspergillosis, aspergilloma. An aspergilloma is a conglomeration of intertwined Aspergillus fungal hyphae and cellular debris, a mycetoma or fungus ball, in a pre-existing pulmonary cavity. The aspergilloma is mobile and will shift position when the patient is imaged in a different position. The most common causes of a pre-existing cavity are prior TB and sarcoidosis. Less common causes include congenital anomalies such as bronchogenic cyst or sequestration, and post-infectious post-traumatic pneumococele. If an aspergilloma is symptomatic, hemoptysis is the most common symptom. Treatment is embolization or resection rather than antifungal medication. When a crescent of air is seen outlining the mycetoma against the wall of the cavity, the correct term is Monod sign. The air crescent sign is reserved for angioinvasive aspergillus. Aspergilloma and Monod sign. CT shows an irregular opacity arrows resting dependent within a left upper lobe cavity, representing an aspergilloma arrows. The Monod sign is the curvilinear air surrounding the aspergilloma. This patient has prior TB with biapical scarring and left apical cavity. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Semi-invasive chronic necrotizing aspergillosis. Semi-invasive aspergillosis is a necrotizing granulomatous inflammation, analogous in pathology to reactivation TB, in response to chronic aspergillus infection. Semi-invasive aspergillosis is seen in debilitated, diabetic, alcoholic, and COPD patients. Clinical symptoms include cough, chronic fever, and less commonly hemoptysis. On CT, there are segmental areas of consolidation, often with cavitation and pleural thickening, which progress slowly over months or years. Airway invasive aspergillosis. Airway invasive aspergillosis is aspergillus infection deep to the airway epithelial cells. It is seen only in the immunocompromised, including neutropenic and AIDS patients. The spectrum of clinical disease ranges from bronchiolitis to bronchopneumonia. The main CT findings of airway invasive aspergillosis are centrilobular and tree in bud nodules. When bronchopneumonia is present, radiograph and CT findings are indistinguishable from other causes of bronchopneumonia, such as staph aureus. Angioinvasive aspergillosis. Angioinvasive aspergillosis is an aggressive infection characterized by invasion and occlusion of arterioles and smaller pulmonary arteries by fungal hyphae. Angioinvasive aspergillosis is seen almost exclusively in neutropenic patients. The CT halo sign represents a halo of ground glass attenuation surrounding a consolidation. The ground glass corresponds to hemorrhage. Halo sign. CT shows a left upper lobe mass with peripheral ground glass, yellow arrow representing pulmonary hemorrhage. Case courtesy Michael Hanley, MD, University of Virginia Health System. The halo sign is not specific to angioinvasive aspergillosis, and can also be seen in viral infection, granulomatosis with polyangiitis, GPA, Kaposi sarcoma, hemorrhagic metastasis, and others. The air crescent sign represents a crescent of air from retraction of infarcted lung and occurs with recovery of neutrophil counts. It a good prognostic sign as it indicates that the patient is in the recovery phase. Air crescent sign. Non-contrast CT shows a lesion in the left lower lobe with a crescent-shaped air collection anteriorly arrows. Pulmonary edema and ICU imaging. Pulmonary edema. Overview of pulmonary edema. Mild pulmonary edema. Radiograph demonstrates moderate enlargement of the cardiac silhouette and sternotomy wires. There are increased interstitial markings with curly B lines arrows. Chest CT shows smooth interlobular septal thickening arrows corresponding to the curly B lines seen on radiography. Mild geographic ground glass attenuation likely corresponds to early alveolar filling. The radiographic severity of pulmonary edema typically progresses through 3 stages, corresponding to progressively increased pulmonary venous pressures. Vascular redistribution is the first radiographic sign of increased pulmonary venous pressure. Imaging shows increased caliber of the upper lobe vessels compared to the lower lobe vessels. Interstitial edema is caused by increased fluid within the pulmonary veins, which surround the periphery of each secondary pulmonary lobule. On radiography, there are increased interstitial markings, indistinctness of the pulmonary vasculature, parabronchial cuffing, and curly B lines. Curly B lines are seen at the peripheral lung and represent thickened interlobular septa. Alveolar edema is caused by filling of the alveoli with fluid. Edema typically has a peri-Heiler central distribution. Pleural effusions and cardiomegaly are often present. CT findings of pulmonary edema include dependent or central ground glass opacification and interlobular septal thickening. Pulmonary edema is usually symmetric and dependent. A classic cause of asymmetric pulmonary edema is isolated right upper lobe pulmonary edema, caused by acute mitral regurgitation secondary to myocardial infarction and papillary muscle rupture. A complication of aggressive thoracentesis is re-expansion pulmonary edema, caused by rapid re-expansion of a lung in a state of collapse for more than 3 days. Support devices. Endotracheal tube. The endotracheal tube tip should be approximately 4 to 6 cm above the carina with the neck in neutral alignment. However, in situations with low pulmonary compliance, e.g., ARDS, a tip position closer to the carina may reduce barotrauma. Direct intubation of either the right or left mainstem bronchus, right mainstem bronchus far more common, is an emergent finding that can cause complete atelectasis of the unintubated lung. Right mainstem bronchus intubation. Chest radiograph shows the endotracheal tube terminating in the right mainstem bronchus, yellow arrow, a few centimeters distal to the carina, red arrow. Central venous catheters. Peripherally inserted central catheter, PIC, in the azygous vein. Frontal radiograph shows a left-sided PIC coursing medially at the confluence of the brachiocephalic vein and the SVC, arrow. Lateral radiograph shows the PIC curves anteriorly before heading inferiorly and posteriorly into the azygous vein, arrow. Case courtesy Beatrice Trotman Dickinson, MD, Brigham and Women's Hospital. The tip of a central venous catheter, including a PIC, should be in lower SVC or the cavotrial junction. Azygous malposition is seen in approximately 1% of bedside-placed PICCs. Azygous malposition is associated with increased risk of venous perforation and catheter-associated thrombosis, and repositioning is recommended. A dialysis catheter should be located in the right atrium. Pulmonary artery catheter. Normal position of a Swan-Ganz pulmonary artery catheter. Chest radiograph with a sharpening filter applied shows a left internal jugular pulmonary artery catheter that takes a normal course through the SVC, right atrium, tricuspid valve, right ventricle, pulmonic valve, and finally the right pulmonary artery, arrow. The tip of a Swan-Ganz pulmonary artery catheter should be in either the main, right, or left pulmonary artery. If the tip is distal to the proximal interlobar pulmonary artery, there is a risk of pulmonary artery rupture or pseudoaneurysm. Other complications of pulmonary artery catheter placement include intracardiac catheter knot and arrhythmia. Lung cancer. Clinical overview of lung cancer. Epidemiology. Lung cancer is the leading cause of cancer death in the United States. Including all stages and subtypes, the 5-year survival is 15%. Risk factors for lung cancer. Tobacco smoking is thought to cause 80–90% of lung cancers. Almost all cases of squamous cell and small cell carcinoma are seen in smokers. Adenocarcinoma is also associated with smoking, but primary bronchogenic carcinoma arising in a lifelong non-smoker without history of secondhand exposure is almost always adenocarcinoma. Occupational and environmental exposures, including beryllium, radon, arsenic, etc., remain important risk factors for lung cancer. Asbestos exposure increases the risk of lung cancer by a factor of 5, synergistic with smoking. Pulmonary fibrosis increases the risk of lung cancer by a factor of 10. Pulmonary scarring, such as from prior TB, also increases the risk of lung cancer. Solitary pulmonary nodule. Overview of the solitary pulmonary nodule. A solitary pulmonary nodule is a well-defined round or oval lesion in the lung. Parenchyma measuring is less than or equal to 30 mm. A lesion greater than 30 mm is a mass. Differential diagnosis includes neoplastic, inflammatory, congenital etiologies. Common mimics on radiograph include nipple shadow, rib lesion, and summation of markings. Solid pulmonary nodules. Calcified nodules, including central, laminar, and diffuse calcification, are almost always benign. Popcorn calcification is suggestive of a pulmonary hamartoma, a benign tumor composed of connective tissue, muscle, fat, bone, and cartilage. Non-calcified nodules can be benign or malignant. Intralesional fat, suggestive of hamartoma or lipoid granuloma, is benign. Amorphous calcification is associated with malignancy, usually mucinous tumors. Non-contrast chest CT on bone windows shows a soft tissue mass with popcorn-like calcifications in the left upper lobe, consistent with a benign hamartoma. Nodule morphology suggesting, but not diagnostic for, a benign etiology. Small nodules less than 3 mm have a 0.2% chance of being cancer and a 4 to 7 mm nodule is malignant in 2.7% of cases. Oblong, polygonal, triangular, flat or geometric in shape, typically intrapulmonary lymph nodes. Subpleural location. Clustering of nodules suggests an infectious process. Nodule morphology suggesting malignancy. Large size is the single most important risk factor for malignancy, regardless of morphology. 0.8 to 3 cm nodules have 18% risk of being lung cancer, and masses greater than 3 cm have a high chance of being malignant. Irregular edge or spiculated margins. Subsolid nodules. Ground glass nodules or mixed attenuation nodules containing both solid and ground glass are more likely to be malignant than a solid nodule. A cavitary nodule or nodule containing small cystic spaces is suspicious for malignancy. Follow-up of pulmonary nodule. The 2017 Fleischner Society Pulmonary Nodule Follow-up Recommendations apply to non-calcified nodules in patients older than 35 without a history of malignancy. Risk factors for malignancy include older age, heavy smoking, emphysema, pulmonary fibrosis, and upper lobe location. Follow-up is not recommended for low-risk patients with solitary or multiple pulmonary nodules less than 6 mm. Any interval nodule growth is suspicious. A 26% increase in diameter, for instance, from 1.0 to 1.26 cm, is a doubling in volume. Doubling time for lung cancers ranges from 42 days in very aggressive tumors to over 4 years in indolent lesions. A solid nodule with well-defined benign morphology that has not changed in size over 2 years is very likely, but not definitely, benign. Longer follow-up is recommended for subsolid nodules as these often represent indolent adenocarcinomas. A decrease in size of a suspicious nodule on a single follow-up study is not sufficient to establish a benign etiology. Transient decrease in size of a malignant lesion can occur with collapse of aerated alveoli or fibrosis. Histologic subtypes of lung cancer. Lung cancer can be thought of as two types: small cell, and all other histologic types that are non-small cell, such as adenocarcinoma, squamous cell carcinoma, etc. Small cell is usually disseminated at diagnosis and has a much worse prognosis. Adenocarcinoma. Adenocarcinoma is the most common subtype of lung cancer. It is related to smoking, but less strongly than squamous cell. Cavitation can occur but is less commonly seen compared to squamous cell. The typical radiologic presentations of adenocarcinoma include: 1. A solitary nodule with spiculated margins due to surrounding reactive fibrosis. 2. Pure ground glass nodule or subsolid nodule with ground glass and solid components. 3. Consolidative adenocarcinoma, which may present as diffuse ground glass opacities or consolidation resembling airspace disease. In 2011, the IASLC ATS classification removed the term bronchial-alveolar carcinoma (BAC) and introduced a new spectrum of adenocarcinoma subtypes. Pre-invasive lesions. Atypical adenomatous hyperplasia (AH). Adenocarcinoma in situ (ICE) non-mucinous, mucinous, mixed. Minimally invasive adenocarcinoma (MIA) non-mucinous, mucinous, mixed. Invasive adenocarcinomas. Lepidic, acinar, papillary, micropapillary, or solid with mucin production. Lepidic growth is a spread of malignant cells using the alveolar walls as a scaffold. The opposite of lepidic growth is hillock growth, demonstrated by most other forms of lung cancer, which describes cancer growth by invasion and destruction of lung parenchyma. Axial CT shows a solid nodule with air bronchograms, yellow arrow, and a more peripheral ground glass nodule, red arrow, both shown to be adenocarcinoma subtypes on pathology. Axial contrast enhanced CT shows a right lower lobe consolidative opacity with air bronchograms, arrow. Adenocarcinoma is an important differential consideration for chronic ground glass or consolidation. Squamous cell carcinoma, SCC. Squamous cell carcinoma, SCC, is slightly less common today than adenocarcinoma. Prior to filtered cigarettes, SCC was more common. SCC most commonly presents as a spiculated nodule, just like adenocarcinoma. However, it can also present as an endobronchial or Heiler lesion. The majority of SCC arise centrally from main, lobar, or segmental bronchi, where the tumor tends to cause symptoms early due to bronchial obstruction. Common radiographic findings are lobar atelectasis, mucoid impaction, consolidation, and bronchiectasis. SCC has a propensity to cavitate. SCC. Axial CT shows a spiculated cavitary lesion, arrow, shown at pathology to be squamous cell carcinoma. Small cell carcinoma. Small cell carcinoma is the third most common lung cancer cell type, after adenocarcinoma and squamous cell. Neoplastic cells are of neuroendocrine origin and are associated with various paraneoplastic syndromes. Small cell carcinoma is strongly associated with smoking. Small cell usually presents as mediastinal or hilar lymphadenopathy, typically presenting as a large hilar or parahilar mass. Involvement of the SVC may cause SVC syndrome. Small cell rarely presents as a solitary pulmonary nodule. The primary tumor is usually not identified. For staging purposes, small cell is divided into limited stage involving one hemothorax and extensive stage disease. The limited stage is treated with chemoradiation, whereas the extensive stage disease is treated with chemotherapy alone. Radiograph. Coronal CT. Axial CT. Small cell carcinoma. Chest radiograph shows a right paratracheal opacity which corresponds to mediastinal and hilar lymphadenopathy on court. The lesion encases but does not significantly narrow the involved bronchi and main pulmonary artery. Large cell carcinoma. Large cell carcinoma often occurs in the lung periphery, where it presents as a large solid mass with irregular margins. Focal necrosis can be present. Histologically, large cell carcinoma is characterized by large nuclei and nucleoli with a moderate amount of cytoplasm. Large cell carcinoma can have rapid growth and early metastasis with overall poor prognosis. Carcinoid tumor. Neoplastic carcinoid cells originate from neuroendocrine cells in the bronchial walls. Carcinoid tumor can either present as a pulmonary nodule, up to 20% of cases, or as an endobronchial lesion. The latter typically is located distal to the carina and may cause obstructive atelectasis. Carcinoid may be typical, low-grade, or the more aggressive atypical variant. Typical carcinoids without nodal or distant metastasis have an excellent prognosis, 92% 5-year survival. Atypical carcinoids tend to arise peripherally and have a worse prognosis. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia (DIPNECH) is an uncommon syndrome characterized by multiple foci of neuroendocrine hyperplasia or tumorlets, carcinoid foci less than 5 mm in size, and bronchiolitis obliterans, as well as multiple carcinoid tumors. Radiologic presentation shows multiple pulmonary nodules with mosaic attenuation of the lungs secondary to air trapping from airflow obstruction. DIPNECH. Axial CT demonstrates several subcentimeter nodules, yellow arrow, and mosaic attenuation of the lungs, red arrow, in a case of diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Pulmonary lymphoma. Pulmonary lymphoma. Axial CT demonstrates a region of dense consolidation involving the right upper and lower lobes with air bronchograms, arrow. Primary pulmonary lymphoma is rare. Most commonly mucosa-associated lymphoid tissue lymphoma, maltoma, a form of extranodal B-cell lymphoma. Most common presentation is mass-like consolidations limited to the lung parenchyma without mediastinal nodal involvement. Pleural-based masses, parabronchial or paravascular thickening, and interstitial infiltrates can also be present. Secondary pulmonary lymphoma is relatively common and includes manifestations of both Hodgkin disease and non-Hodgkin lymphoma. CT imaging features include lymphangitis, nodular, or consolidative pattern. Hodgkin disease presents as parenchymal involvement with lymphadenopathy as contiguous spread of disease and may cavitate. Post-transplant lymphoproliferative disorder, PTLD, presents as new pulmonary nodules in a patient after solid organ transplantation. Lymphadenopathy is often present. PTLD. Axial CT demonstrates a new nodule, arrow, in the right lower lobe in a patient 7 months following bilateral lung transplantation. This was biopsied, with pathology of post-transplant lymphoproliferative disorder. Radiologic presentation of lung cancer. Segmental or lobar atelectasis. Atelectasis due to bronchial obstruction is a common presentation of lung cancer. Despite the presence of atelectasis, volume loss is variable, secondary to the volumedisplacing effects of cells, mucus, and fluid. Obstructive pneumonia is a common presentation of lung cancer, caused by bronchial obstruction and parenchymal consolidation by inflammatory cells and lipid-laden macrophages. If two foci of atelectasis are present simultaneously that cannot be explained by a single endobronchial lesion, a benign process is much more likely. Consolidation. Consolidation that is indistinguishable from pneumonia can be seen with adenocarcinoma. Although adenocarcinoma and pneumonia may appear similar, adenocarcinoma is usually a non-resolving consolidation with near normal white blood cell count. Heiler mass. Lung cancer presenting as a Heiler mass. Frontal radiograph, left image, shows a right paramediastinal opacity, arrow, which does not silhouette the right heart border. CT shows a large right infrahilar mass, arrows. A Heiler mass is a common presentation of squamous cell and small cell carcinoma. Heiler enlargement may be due to a primary central tumor or nodal metastasis from a parenchymal neoplasm. Tumor may compress and narrow the bronchus. Superior sulcus tumor. Superior sulcus tumor. Chest radiograph shows nearly imperceptible increased opacity in the right apex arrow. A superior sulcus mass is clearly evident on court arrows, with encasement of the vasculature and effacement of the superior mediastinal fat. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. A superior sulcus tumor is a lung cancer occurring in the lung apex. A Pankos tumor is a type of superior sulcus tumor with involvement of the sympathetic ganglia causing a Horner syndrome, with ipsilateral ptosis, meiosis, and anhydrosis. A superior sulcus tumor is a stage T3 tumor. The staging of lung cancer is subsequently discussed. Lymphangitic carcinomatosis. Lymphangitic carcinomatosis. Axial left image and coronal CT shows asymmetric, nodular septal thickening of the right lung in a patient with metastatic uterine sarcoma. Aside from a trace effusion, the left lung is clear. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Lymphangitic carcinomatosis represents diffuse spread of neoplasm through the pulmonary lymphatics, typically seen in late-stage disease. On imaging, carcinomatosis manifests as smooth or nodular interlobular septal thickening, which is often asymmetric. Pleural effusion. Pleural effusions are relatively common in lung cancer, which may be due to lymphatic obstruction or pleural metastasis. A malignant effusion is the presence of malignant cells within the effusion. A malignant effusion is an M1A lesion, which precludes curative resection. Not all effusions associated with lung cancer are malignant effusions, so cytologic evaluation is necessary. Staging of lung cancer. Overview of lung cancer staging. The 8th edition of the TNM system, published in 2018, is based on data collected on over 77,000 patients with lung cancer from 1999 to 2010. The 8th edition recategorizes tumor size by upstaging T classifiers to reflect that survival is inversely proportional to every centimeter increase in size until 7 centimeters. At this point, the same prognosis as T4 disease is reached. Extrathoracic metastases that were classified as M1B in the 7th edition are further subcategorized into M1B oligometastatic and M1C multiple metastasis in the 8th edition, to better define oligometastasis, which has a better prognosis and may benefit from more aggressive local therapy. Treatment based on staging. For early stages up to IIB and sometimes IIIA, surgery is usually performed. Neoadjuvant or adjuvant chemotherapy and radiotherapy can be used. Stage IIIB N3 contralateral or supraclavicular nodes, or T4N2, is unresectable. Stage 4 disease is generally not treated surgically unless there is a solitary adrenal or brain metastasis. T. Tumor. T1. Tumor is less than or equal to 3 cm surrounded by lung or visceral pleura. T1A. Tumor is less than or equal to 1 cm. T1B. Greater than 1 and is less than or equal to 2 cm. T1C. Greater than 2 and is less than or equal to 3 cm. T2. Tumor greater than 3 cm and is less than or equal to 5 cm, or local invasion of the visceral pleura, or endobronchial lesions. T2A. Greater than 3 to is less than or equal to 4 cm. T2B. Greater than 4 and is less than or equal to 5 cm. T3. Tumor greater than 5 to is less than or equal to 7 cm, or local invasion of chest wall, pericardium, phrenic nerve, or metastatic nodules in the same lobe. T4. Greater than 7 cm, or invasion of mediastinum, diaphragm, heart, great vessels, recurrent laryngeal nerve, carina, trachea, esophagus, spine or separate tumor nodule in a different lobe in the ipsilateral lung. N. Nodes. The color coding of the lymph nodes on the diagram on the following page represents the nodal staging of lung cancer for an example left-sided mass. N1. Ipsilateral Heiler nodes and intrapulmonary nodes 10 Heiler. 11 interlobar adjacent to interlobar bronchi, 12 lobar adjacent to lobar bronchi, 13 segmental. 14 subsegmental. N3. 1 supraclavicular nodes any side, any contralateral node. N2. Ipsilateral mediastinal nodes 2 upper paratracheal. 3 provascular anterior to aorta, not shown, 4 paratracheal. 5 subaortic AP window. 6 paraortic. 7 subcarinal. 8 parasophageal. 9 pulmonary ligament. The boundary between right and left for level 2 and 4 lymph nodes is set as the left lateral border of the trachea due to number 1 F. Au of lymphatic drainage. In this example of a left-sided primary, the right-sided nodes are drawn in orange to demonstrate N3 due to contralaterality. AP window. Between aorta and pulmonary artery. N0. No lymph node metastasis. N1. Ipsilateral hilar or intrapulmonary lymph nodes, green in diagram above. N2. Ipsilateral mediastinal nodes, yellow in diagram above. N3. Contralateral mediastinal or hilar lymph nodes, or supraclavicular nodes on either side, orange in diagram above. M. Metastasis. M0. No metastatic disease. M1A. Local thoracic metastatic disease. Separate tumor nodule in contralateral lung malignant pleural or pericardial effusion. M1B. Single extrathoracic metastasis, including single non-regional lymph node. M1C. Multiple extrathoracic metastasis in one or more organs. Exam